Welcome to this presentation, which is focusing on outpatient presentations to respiratory medicine. So we're going to look at a few cases which essentially are all GP referrals into the respiratory clinic. The idea is that this presentation will complement your workbook and respiratory booklet as well. And it's really trying to give a bit of an overview of managing chronic diseases, which is obviously different to the sort of previous presentations you've had, focusing on acute admissions and acute care. So, as I said, these are all going to be GP referrals. We're going to have a look at 4 virtual cases. So the first one is a 65-year-old man who's got a 40-pack year smoking history, still smoking, 6 months of breathlessness on exertion, also productive cough, and a body mass index of 18. So that's the kind of referral that we might get through from a GP or another healthcare colleague to our sort of clinic service. So with that information, even before we see the patient, what kind of differential diagnosis might you contemplate? Okay, well, we'll come back to that, but just when we see the patient, we really obviously take a more detailed history, and on sort of discussion with the patient, he describes being breathless with cough, 6 months of breathlessness, really with a reduced exercise tolerance now, 500 meters, struggling to walk up hills. The breathlessness is relieved by resting. In terms of the cough, it's been generally productive, a few mils, less than 5 mils per day of sputum, no chest pain, no wheeze, no hemoptysis, and no orthopnea. In terms of past history, he's got hypertension, high cholesterol, and he's on amlodipine and simvastatin for those. Denies any drug allergies. In terms of family history, his father had a myocardial infarction, age 73 years. Patient himself is a smoker, having accumulated 50-pack years. Recently retired, but always worked as a painter and had possible asbestos exposure some 25 years ago. Otherwise, not really anything else of great note from the history. So when he's examined in the respiratory clinic, he is comfortable at rest, but he has got a barrel-shaped chest. His respiratory rate is normal at 16 per minute. Examining his hands and face and neck, there's no peripheral stigmata or clues to suggest any significant respiratory pathology. And then really sort of when we get into closer examination, it's all fairly normal on his chest. So the only thing really of note is this barrel-shaped chest. So in summary, he is 65, retired painter, 6 months of progressive breathlessness on exertion, with a reduced exercise tolerance, struggling going up hills and inclines. Also this associated productive cough, fairly low volume each morning, background of high blood pressure, high cholesterol on amlodipine and simvastatin, and still smoking with 50-pack years in total. Possible asbestos exposure some 25 years back. Examination fairly normal, apart from the fact he's got this barrel-shaped chest, and also, as we noted from the GP referral, he is underweight with a body mass index of 18. So differentials, and then moving on to sort of probable or useful initial investigations. So I think I've mentioned this before, there are different approaches in terms of clinical reasoning to try and work out either your differentials or your main diagnosis. And one is sort of pattern recognition, where you've got a disease that fits the story. And using that approach, I think this does seem like somebody's probably got COPD as a most likely diagnosis, as you'll probably all agree. But I mean, there's some other possible diagnoses to consider, which could present in a similar way. Such as heart failure and other respiratory chronic conditions like bronchiectasis or interstitial lung disease. And of course, with that asbestos history, again, we should be mindful of some possible underlying asbestos-related disease. The second approach to clinical reasoning is using a more symptom-based approach. So given that we know that it's got progressive breathlessness, there's obviously lots of differentials for that, but the main things which are common are COPD, heart failure, ILD, interstitial lung disease, or PE. And with the chronic productive cough, again, there's a few things which are more likely to cause that, which are listed there. So as we can see, it doesn't really matter which approach we're using. We're getting similar likely diagnosis of COPD and also similar common differentials that we should probably exclude as well. So again, whichever method you use, it doesn't really matter. As you can see, they should generally come to the same diagnostic conclusion. So as we said, COPD seems most likely. We should consider, I think, heart failure, ILD, bronchiectasis. Certainly lung cancer would be something to exclude given the progressive cough and the sort of duration of symptoms, and also the patient being underweight as well. So in terms of investigations, if we're thinking COPD is the most likely thing, then how do we diagnose COPD? Well, we need just spirometry and the history. So certainly spirometry would be very useful. The chest X-ray would be really useful, mainly to exclude some of the other key differentials. And again, if we're not really sure what's going on, despite having done those initial tests, and we're still thinking about something else, such as heart failure or some other underlying respiratory pathology, then clearly, investigating for those things would be useful. So heart failure, a BNP blood test, possibly as an echo, and then for any other respiratory underlying pathology, and CT thorax may be of benefit. So this patient does have his spirometry performed, and we can look at the values that he's actually demonstrating in the table. So we can see essentially his current FEV1, forced expiratory volume in 1 second, is 1.7 litres. His predicted should be 4 litres, so therefore he has a 42% really value of his best predicted. Similarly, he has a reduced forced vital capacity, as you can see, but not in the same degree in reduction as his FEV1. So his FEV1 FVC ratio comes out as 55%, 0.55. So essentially, as you'll recognize, that is in keeping with an obstructive deficit. And therefore, given the history, really, we've got a diagnosis of COPD here. So thinking about that, what do we think the management is? Given that this is a chronic presentation, this is not an acute exacerbation, so we mustn't get mixed up with that. This is, the question is, how do we manage somebody with chronic disease who's presenting with long-term symptoms, essentially? Well, I guess the answer to any question when you're asked about managing chronic disease, doesn't matter what it is, whether it's COPD or chronic renal failure, CKD, or chronic heart failure. Nowadays, there'll be probably some sort of care bundle that exists, which essentially is a multidisciplinary team approach to try and help this patient in terms of quality of life and symptom management. So as you know, COPD is not reversible, so we can't get rid of it essentially unless somebody, for example, has a lung transplant, but that's something which is not very common. So the care bundle approach tries to address a few things which we think are really going to give benefit to the patient based on previous evidence-based medicine. So we can see smoking cessation clearly is top of the list, really important. It's going to have big impact, also in terms of mortality. Pulmonary rehabilitation, which you're aware of, is well evidenced to show benefit in terms of potentially improving exercise tolerance, but also symptoms in general, and therefore improving quality of life. We have a variety of pharmacological interventions that we may opt for, And inhalers we have, there's a number of different things on the market now made by different companies, lots of different devices, but in general, the categories would be bronchodilators, antimuscarinics, and inhaled steroids. In addition, we have the option of mucolytics, such as carbamazepine tablets, which can help if patients are finding that they've got lots of sputum which is difficult to clear. And of course, nutrition is very important. So remember, our patient, low body mass index of 18. So therefore, again, it's really important that he has some input from the dietitian in the MDT, and then that will essentially entail helping to improve calorie input. We may need nutritional supplements for that, or there may be just some dietary advice which is recommended to try and help the patient prevent any further weight loss. And weight loss is common in chronic disease, particularly chronic respiratory disease. So again, it's really important that we do address nutritional intake for those patients. LTOT stands for long-term oxygen therapy, and that I've said here, if appropriate, because it's only really indicated if patients have proven respiratory failure. So if you remember back to our case, this patient, this scenario, he's got saturations of 94% on air, so therefore he does not really fulfill the criteria for having respiratory failure. If, on the other hand, if he was presenting more hypoxic, for example, if his SATs were below 88% or even below 94%, I guess you would probably do some sort of investigation in terms of a blood gas. And if a patient has persistently low PO2 levels, then we might consider offering them long-term oxygen therapy. We'll talk a bit more about that as the presentation continues. Also, lung volume reduction is mentioned here, and again, I've said if that's appropriate, and that is an intervention which can be done by surgeons, but actually also we've got medical lung volume reduction, which is developing now, which can be done using bronchoscopic valve insertion. But this kind of procedure is only really reserved for patients who've got generally different areas of lung affected by the COPD, by the emphysema essentially. And essentially, if a patient has got very diffuse emphysema, then they're not going to be a candidate for this kind of procedure. If, on the other hand, if they have predominantly the upper lobe of one of the lungs affected much more than the lower lobe, for example, if there's that disproportionate involvement, that's what we call heterogeneous emphysema change, then that patient may be a candidate for essentially having the sort of really diseased part of the lung removed by a lung, and that's what we call lung volume reduction. And that can just help the remaining part of the lung to sort of work more efficiently physiologically. But again, that's only reserved for certain patients. Like I said, it's the ones who usually have this heterogeneous pattern of emphysema, and therefore there's actually not so many patients who are actually eligible for that. So there's three things on this list which are essentially in block capitals underlined, and that's because they are things which can actually have a mortality benefit. So clearly we know the benefits of stopping smoking, and long-term oxygen therapy, if appropriate, or lung volume reduction, if appropriate, can also influence and improve mortality outcomes. So I guess to summarize, for our patient who has essentially a FEV1 of 55% and a body mass index of 18, with saturation of 94% on air, the summary of his initial care bundle approach would be certainly smoking cessation, definitely. Pulmonary rehabilitation would be appropriate. He may benefit from some inhalers, such as bronchodilators or antimuscarinics in the first instance. He may benefit from mucolytics if that was thought to be an issue that he's having difficulty expectorating. And he certainly needs some input from our dietitian and nutritional team. At the moment, he's not a candidate for long-term oxygen therapy, and we don't know about whether or not he'd be a candidate for lung volume reduction, because we haven't done a CT scan yet, which is what you need in the first instance to determine whether or not there's heterogeneous emphysema or not. So this is an old slide which I think I've showed you before, or you may have seen previously in phase 1. And it's a very old slide from the BMJ 1977, but I still like it because it really, what it does demonstrate is, if we look at the top curved line on the graph, essentially we can follow that, and this really represents people who do not have any underlying disease, and it really just shows that, you know, no matter what is your underlying disease, whether you're well or not, from a respiratory point of view, you're going to have a natural decline with aging in your FEV1. So as we get older, our FEV1 starts to decline after you've peaked, usually in your mid-20s. What this graph also suggests is that if you are a smoker, you're susceptible to getting COPD as a result of smoking, then you're more likely to have a faster rate of decline in your FEV1. But interestingly, if you stop smoking, it doesn't matter what age you stop. So in this example, for example, if you stop around the age of 60, or even, you know, around the age of 50, or, you know, even later in life, you know, in your 60s, doesn't matter how old you are, when you stop smoking, you are going to slow the rate of deterioration of your FEV1 down. So essentially the message is useful to sort of discuss with patients, really trying to enforce that it's never too late to stop smoking. And it's really important that we try and get these kind of messages across to our patients. So pulmonary rehabilitation is a really useful intervention, which has a lot of evidence to back it up. And it really essentially works by breaking a vicious cycle. So this picture really demonstrates this vicious cycle in a very simplistic form. So patients get breathless. As a result of that, they avoid activities that make them feel breathless. So things like walking exercise. Therefore, they do less. In other words, they end up doing less exercise. As a result of that, their muscles weaken. They get a reduction in skeletal muscle mass. And as a result of that, they get more breathless. They then may become more depressed as a result of all of these things. With depression, then they may end up not going out of the house as much, or they may end up having a reduced appetite. And then as a result of that, they again do less. Their muscle weakness increases. And you can see how this is a self-perpetuating vicious cycle. So the idea of pulmonary rehabilitation is essentially just to break this vicious cycle. And it's, you know, ultimately a supervised program led by an experienced COPD MDT, which can involve a variety of healthcare workers, including physios, physiologists, occupational therapists, dietitians, as well as physicians. And it's essentially a supervised exercise program to try and get patients moving, but to try and improve their exercise tolerance. And ultimately, you know, evidence suggests very clearly that this can help improve both exercise tolerance, but also, more importantly, improve symptoms on a day-to-day basis, and therefore improve quality of life. Other benefits from pulmonary rehab include getting education. So again, you know, discussions about things like nutrition, but also, you know, what common symptoms are, what impact they may have on daily life. There's also opportunity to get peer support from other patients. And again, this, you know, can be done virtually online, given that we're having at the moment less patient face-to-face contact. So you know, it's a very useful intervention, and it's an important thing to recognize. And clearly, you know, it's something which is, you know, obviously not a significant financial resource, because we're talking about patients doing exercise. The main resource here is staff time, and you know, having the infrastructure to have the team in the first place. long-term oxygen therapy. So this is essentially, as I've previously alluded to, something which may be appropriate for patients who have persistent evidence of respiratory failure. But just thinking about why we use oxygen in the first place in the chronic setting. So really, extended periods of hypoxia can cause damage, particularly to other organs. So we really think about kidneys, heart, and of course the brain as well. And the idea of long-term oxygen therapy is essentially to help preserve these other organs being damaged by hypoxia. So really, it can give a survival benefit for by using oxygen in patients who have respiratory failure by helping to essentially protect these other organs. But the only way to get that survival benefit is to use the oxygen for at least 16 hours per day. So that's important because when we're having discussions with patients about whether or not they may commence long-term oxygen therapy or not, it's important to tell them that the reason we're giving them the oxygen is to help make them live longer. And the only way they're going to live longer is if they actually use the oxygen for at least 16 out of 24 hours per day. The second thing really to stress to patients is that this is not a treatment for breathlessness. So it's a bit of a misperception, I think, with patients, but also some healthcare professionals, that oxygen can actually help breathlessness. It's not a treatment for breathlessness. In this indication here would be a treatment for essentially helping people to live longer. So the indication for giving it is if somebody's got proven respiratory failure, and the sort of guidance we've got is that essentially if somebody persistently on a blood gas has a PO2 of less than 7.3 kilopascals. So when we say consistently below that level, that means at least on more than 2 occasions. So there's no point just doing it on a one-off occasion, because actually that one-off occasion could be when the patient's in the middle of an effective exacerbation. So we want to make sure that we've got some sequential time between 2 separate checks, and if it's persistently low, then they may be a candidate for long-term oxygen therapy. If a patient has cor pulmonale as well, in other words, right heart failure as a consequence of their underlying COPD, then that guidance is slightly changed. In those patients, a PO2 of less than 8 kilopascals would be deemed appropriate to fit the criteria. The caveats for this are that patients must not be smoking, because that's clearly a fire hazard around the oxygen, and also they must not retain high levels of carbon dioxide. So the way that we'd essentially look at that practically is the patient may come in actually as a day case, if we're thinking of offering them long-term oxygen therapy to, for example, a respiratory physiology unit. And they would have a baseline blood gas check. Usually we use earlobe gases in clinic, which are more comfortable for the patient. And essentially, if the PO2 was less than 7.3 or less than 8, if they had cor pulmonale, the patient would be then put on oxygen in a supervised setting in the respiratory physiology day case visit. They put the oxygen on, for example, for about 20-25 minutes. And then recheck the blood gas at the end of that to make sure that the carbon dioxide level is not climbing. So that's essentially how we make sure that they're not very sensitive to the oxygen. So if all those parameters are met, then there are oxygen providers. Each county has a service agreement with a particular oxygen provider, who essentially will then go to the patient's home and install an oxygen concentrator, which is a small box which usually fits in a cupboard or under the stairs, for example, and then that essentially helps to generate the oxygen the patient needs. They're given enough length of tubing so that they can move around the house with that. And essentially, again, as we said before, it's important if they're going to do that it's going to be at least 16 out of 24 hours per day to get that survival benefit. Okay, so I think moving on to our second different patient now. This is a GP 2-week wait referral with suspected lung cancer. And the patient essentially is a 60-year-old man who's referred with cough for 5 months. It's an intermittent clear sputum, but he has had the occasional streaks of hemoptysis and also 1 stone of weight loss as well. He is still smoking with 40 pack years accumulated. He's a HGV lorry driver with no known asbestos exposure. So this is an initial chest X-ray that the GP has arranged and hence why he's referred up to the suspected lung cancer service. So as we can see in the X-ray in the left mid-zone, there is this quite discrete dense shadow, which is potentially in the left hilar region, but it's difficult to say that for definite on an X-ray. But what we can definitely say is there's a left mid-zone shadow on this X-ray, which, given the history of the patient and the smoking history, makes us very suspicious for lung cancer. So the way that our service runs in Leicester, and I think it's similar in other hospitals, is that when we get these kind of referrals come through, we will arrange a pre-clinic staging CT scan. So if you remember, staging CT scan of the lungs is essentially a continuous scan from neck to mid-abdomen, essentially looking at all of the lungs, but also the reason for scanning to the middle of the abdomen is to look for common sites of metastases in lung cancer, which are the adrenal glands and liver. So this patient does have a pre-clinic staging CT scan, which confirms a radiological diagnosis of lung cancer. And in terms of staging, it's staged as T3, which refers to the size of the tumour, N2, which refers to nodal involvement, and M0, implying that there's no definite distant metastases on the CT that we can see so far. So what we're going to do next? Well, clearly we need to get the patient to come to our suspected lung cancer clinic to now discuss essentially the CT diagnosis. And this is really a sort of breaking bad news scenario, and this is how the majority of first appointments to any suspected cancer clinic, if there's a positive diagnosis, would sort of that's really what happens in those settings, which is, first thing is give the potential diagnosis, break the bad news. So if you remember our mnemonic for breaking bad news, we've got spikes, so that it really implies, S is the setting. Have we got appropriate sort of quiet space, quiet, we're not going to be disturbed room, you're not going to be phoned in the middle of that you can have a conversation with your patient. Ideally, the setting should also include the personnel there. So again, if the team's well set up, there should be, for example, somebody to support you and support the patient, such as a specialist nurse also present. P is perception, so you're really finding out what the patient already knows before you try and think about giving them the bad news. I is, using some sort of icebreaker. There's a skill to sort of gently trying to tell the patient something not right here, there's something wrong, before you, essentially weigh in and give the full diagnosis. And then K is knowledge, in other words, giving the diagnosis and any other important information that you think is required on this first discussion. E is clearly empathizing with our patients and any relatives that they have present with them. And S is summarizing. So again, if you give somebody bad news, often it doesn't really sink in. And if there's, maybe 1 or 2, 3 key messages that you want to summarize, for example, next steps, then that's the time to do that. So what we need to really explain to this patient is that they need to have some sort of biopsy to confirm the histology. The reason for that is that there are different types of cancers. So, for example, non-small cell lung cancer, small cell lung cancer. It could even be, bizarrely, a metastases from a different organ. We just don't know that at the moment. So it's really important to find out exactly what type of cancer it is, what kind of cells there are, The lab can do a variety of more advanced techniques now, including sort of cell types and different characteristics of markers, which might actually guide the oncologist to think about specific chemotherapies and also more targeted therapies as well. But unfortunately, in this case, with this patient, they've actually got a very big tumor, and it's a very advanced stage of cancer. And therefore, when you've got an advanced stage of cancer, then the chances of, essentially a reversible cure, such as surgical resection, certainly become more limited. So that would be the kind of approach in our suspected lung cancer clinic within the first visit. In addition, we think about evaluating the fitness of our patients, so we can do that really from a history. So we can evaluate what their performance status is. So that really is a World Health Organization scale of essentially how fit somebody is. What can they do? What do they need help with? Are they chair bound or are they bed bound? Those kind of things are taken into consideration. And performance status is really important because it will help also guide how fit patients are for certain treatments. So, for example, if we're thinking about chemotherapy or some sort of aggressive surgical intervention, then patients need to be fit for that. So the higher the performance status of the patient, in other words, the least fit they are, the less likely they are to be able to be eligible for some of these conditions. Sorry, for some of these treatments, I should say. We'd also like to get some spirometry at this stage, because that may be useful if the patient is embarking on some sort of surgical procedure at some point. But obviously in this case, for our patient, unfortunately, that's not going to be the case because of their advanced stage of cancer. And then we would basically think about what's the best way of getting this biopsy for histology. There's different options, and it will be determined really by where the tumor is located. So, if, for example, the tumor is very peripheral in the lungs, then it may be something that the radiologist can essentially get to via CT guided biopsy. If the tumor is infiltrating the bronchial tree, in other words, it's something that you could see during a bronchoscopy, then that would be potentially a good test. We have something called EBUS, which is endobronchial ultrasound, which essentially is useful if patients have significant lymphadenopathy in their mediastinum, which may be essentially amenable for us to get samples from using the specific specialized bronchial procedure. Thoracoscopy may be appropriate if somebody's got pleural effusion. So again, there's different options which would depend on the location of the tumor, but also the expertise within your lung cancer MDT. And then the next step is to have a discussion with the MDT with all the results available. So you can understand this is going to take some time to get these processes done. So, for example, we've got this 2-week wait process, so patients need to be seen within 2 weeks of that initial GP referral. Then you can imagine there's, they'll have had the CT scan by then, but you can imagine there may be a wait of, a day or two, or maybe even more to get their biopsy test, whatever that is. And then we need to give the pathologist a few days to process those histological samples. So that whole process can take a few days or even a week or longer to get essentially to the stage where we're then able to have that discussion with the MDT with the results, and then obviously refer on to the appropriate treatment modality. And in this case, for our patients with advanced lung cancer, they're not amenable to a surgical resection. They may be amenable to palliative chemotherapy, but certainly palliative care would be appropriate in helping this patient. So just as a reminder, there are other ways that lung cancer can present. So, they may present with pleural effusion initially, so that, they may present, for example, with progressive breathlessness on exertion, and then examining the patient and an X-ray may give a picture like this in the top left. Somebody may present with finger clubbing, and finger clubbing may be the only sign that they've got, as some sort of underlying cancer diagnosis. And we shouldn't forget about Horner syndrome, which is shown in this picture of somebody's eyes. And in that picture, we can see on the left side, in the left eye, there is ptosis. And it's not entirely clear on this picture, but there is a sort of difference in the size of the pupil. So you get a smaller pupil, essentially, in Horner syndrome. And it's really a triad of ptosis, small pupil, and a loss of localized sweating, which is a bit more difficult to pick up as a sign. But this picture shows somebody's got left Horner syndrome, which is indicative of probably a left-sided lung cancer, and that's usually an apical cancer called Pancoast tumor, which will then infiltrate the sympathetic nerve supply on the same side as the lesion. In this slide, we can see a patient who's presenting with something called superior vena caval obstruction. So examining the patient's thorax, essentially you can see quite a lot of tortuous veins on the surface of the skin. And again, it's not obvious from this picture, but they've got engorgement of their upper limbs, head and neck as well. So these are all areas which essentially are drained by the superior vena cava. And as a result of a tumor compressing the superior vena cava, which you can see on the CT scan, if you look at the arrows of the CT scan, this is a tumor which is just squashing into the mediastinum and squashing the SVC. So we get essentially a reduction in venous return via the superior vena cava, the SVC, and that causes clinical consequence of head and neck and upper limb engorgement with these sort of tortuous veins sometimes seen as well. So that is essentially a medical emergency, and urgent attention is required. Patient needs urgent assessment and admission to hospital, essentially for treatment to try and alleviate that SVC obstruction, and that may include possibly radiological stenting, or it may include oncological therapy to try and shrink that tumor in the first instance, to try and alleviate some of that pressure on the superior vena cava. So in terms of different histological types, there are many. I'm not going to go through these in great detail at the moment. You're going to learn a lot more about lung cancer in year 4 in the cancer care block. So really the purpose of today is just to try and make us aware of how patients present when diagnosing lung cancer. But just for interest, we can see here non-small cell lung cancer cases. The overall 5-year survival is still fairly poor. Now, clearly, if patients present with earlier stage, in other words, they've got, for example, smaller tumors like stage 1 with no, widespread involvement, no lymphadenopathy or no significant lymph node spread, and certainly no metastases, then they may be clearly amenable to surgical resection, which can have a cure. And again, we can see that there's 60-70% 5-year survival. If somebody has stage 1 cancer presenting and then they have successful surgical resection. But clearly, unfortunately, as we see down below, as the stages advance, the 5-year survival really becomes much worse. So our patient today is presenting clearly with a sort of stage 3 tumor, really a sort of fairly poor overall outlook. Small cell lung cancer is a different histological subtype, and it itself has generally a worse prognosis from non-small cell lung cancer, although some patients do have good outcomes, again, depending on how advanced the cancer is initially, and whether or not they can start treatment promptly. But again, just for interest, I've mentioned a few things here, but again, you'll learn more about this in your cancer care block in year 4. So just as a reminder of this slide, it's really important, essentially we shouldn't ignore symptoms. And this is the problem with lung cancer. Patients present generally fairly late, which is why generally the outcomes and the mortality is so bad. So really it's important that we make sure that patients do not ignore symptoms. They must go and see the doctor if they've got symptoms. So that this campaign really suggests if you cough for 3 weeks or more, you should go and see a doctor, and ideally then you should have a chest x-ray at the very least. This does bring into question whether or not we should be doing lung cancer screening nationally, and this may happen in due course. We've not reached that point yet. There are some local screening programs being developed and piloted around the country, and clearly I think screening patients at higher risks on a routine basis, at least with a chest x-ray, but ideally also with a CT scan, seems like probably a sensible approach. Because if the problem is that lung cancer patients are presenting too late, then we need to try and pick it up earlier by screening. One of the reasons why screening for lung cancer has not become widely available yet is partly because of the fact that if you do a CT scan on your whole population, you're going to pick up a lot of incidental findings. So one such incidental finding that we often see when we do a scan of somebody's thorax is something called a pulmonary nodule. And essentially pulmonary nodules are little lumps which exist in the lungs, and these can be benign, but also they can be essentially early cancers. So again, those patients will need ongoing follow-up. They may need repeat CT scans at periodic times to sort of ensure that those nodules are not growing. So you can see if that is a large finding on a screening program, then essentially you're going to have a lot of patients having repeat CT scans. And at the moment, there's an argument that we may not have resources in every region to offer that number of CT scans, but also in terms of radiologists' availability for reporting all of these extra scans. But I'm sure that the situation will change. I would be surprised if we don't have some sort of lung cancer screening program in the near future. So in terms of lung cancer, clearly quality of life for any condition is important, particularly in cancer patients. And as we said, most patients with lung cancer present late and therefore will not be eligible for curative procedures or treatment. So therefore, it's really important that we do everything we can to try and optimize quality of life, and therefore we're seeing really increasing input from our palliative care teams, earlier rather than later. So just to summarize that lung cancer management, it's very, very brief summary here. It's not in any significant detail. As I've said, again, you're going to learn about this in more detail in the Year 4 Cancer Care block. But just to summarize, we've got a patient who's referred by the 2-week wait process. It's really important that we encourage our patients to not ignore symptoms, and if we're working in primary care, that we refer patients as early as possible if there's any suspicion of cancer whatsoever. Our MDT for lung cancer has got a multitude of healthcare professionals, which the list seems to grow frequently. Clearly, histology is important, irrespective of the stage, because we need to find out what subtype of cancer it is. That may influence treatment modalities. And then we have different options for treatment depending on patient's stage of tumor and their fitness or performance status. So our third patient is a 24-year-old who presents with a history of recurrent chest infections, which have been going on since childhood, along with intermittent green sputum. They've also got occasional streaks of hemoptysis. So they've had an x-ray, and again, it's not entirely clear on this x-ray, but you can see it doesn't look quite normal. And, sometimes it's difficult to sort of say exactly what the abnormalities are, but you can see that, essentially in the right upper zone particularly, there is an area or a patch which, if you look closely, almost looks like there are almost like sort of lots of rings sort of attached together or grouped together. So again, there's almost like little circles And again, if you look throughout, again, even the right mid-zone, some sort of possible sort of little ring lesions, and even on the left side, it's not as clear, but there are some, particularly in the upper zone. So based on this presentation and the X-ray, I guess the question is, what do we think is the diagnosis? And then secondly, therefore, what tests should we request? Well, really, this is a young patient, recurrent chest infections. They've got productive cough, hemoptysis. I think we would really be wanting to exclude bronchiectasis at this stage, but of course, something more sinister like a cancer may well be in the mix, but we don't think there's definite malignancy from the X-ray. But in any case, the patient's going to need a CT scan. And if you think they've got bronchiectasis, then a high-resolution CT scan is the gold standard diagnostic test. In addition, given that the sputum production, we need some sputum cultures sending off. So that's exactly what we do. So the sputum comes back positive for pseudomonas aeruginosa. Sputum investigation for non-tuberculous mycobacteria is negative. And as you've seen this on several examples before, on the CT scan, we can really see some good examples of bronchial dilatation, bronchial wall thickening, and the bronchi, which are dilated far more than the adjacent white blob blood vessels. So this is essentially a very good example of bronchiectasis on a CT scan. And again, we've got these dilated bronchi, which are adjacent to blood vessels, which are smaller in diameter than the bronchi, and that's what we call a signet ring sign. And I've put a question mark there because I'm not quite sure why whoever named it in the first place called it signet ring, because it doesn't really look like a signet ring. It's more like a kind of diamond engagement ring to some extent, but it doesn't really matter. That's what it's called. That's a radiological description. So thinking about cause of bronchiectasis and then subsequent management. So there's lots of causes of bronchiectasis, but really the causes of bronchiectasis to some extent help us to define what investigations would be appropriate to do, because it's important when we diagnose somebody with bronchiectasis that we do consider and try and find out what is the underlying cause of that bronchiectasis. Now, the majority of patients presenting with bronchiectasis will have essentially a post-infective bronchiectasis. In other words, they've had some sort of severe infection early in life, and I've not really put the full exhaustive list here, but that would typically be any virus, but whooping cough's the more common one reported. Any atypical infection like TB, but also more common infections, so pneumonia itself could lead to post-infective TB. Immune deficiency, so particularly hypogammaglobulinemia, so therefore it's important that we check this patient's blood test for immunoglobulin levels. And then we've got our mucociliary clearance defects, which essentially are our genetic conditions, of which cystic fibrosis is the commonest one that we see in the UK. And therefore, given that we've got a fairly young patient who's presented with a lifelong history, for whatever reason they've not been picked up before, but now that they're with us now, we should be screening them for cystic fibrosis, if that's appropriate, also considering some of the other genetic conditions which are listed here. Now, other causes of bronchiectasis include things like obstruction, which could be due to a foreign body or a tumor, toxic insult for any reason, but also, that could be, things like chemical warfare. It could just simply be gastric aspiration for a variety of reasons. There's a condition called allergic bronchopulmonary aspergillosis, which is a mixed type 1, type 3 hypersensitivity reaction where patients are hypersensitive to environmental aspergillus, which is a very common fungus. Some sort of secondary immunodeficiency, such as HIV or as a result of underlying cancer. Rheumatoid arthritis and other conditions like inflammatory bowel disease are also associated with bronchiectasis. and also something called yellow nail syndrome, which kind of says what does what it says in the can, which is you get yellow nails and also bronchiectasis developing. So just coming back to our patient, really, what investigation we're going to do? Well, certainly we're going to do some blood testing for immunoglobulins. If there was a history of joint pains, which there isn't really, then we might consider doing a rheumatoid factor. It would be relevant to do an HIV testing. That's appropriate, yes. We'd probably screen for this, ABPA, allergic bronchopulmonary aspergillosis, as well by doing some blood tests, which are helpful for that. But certainly we should be doing some screening for cystic fibrosis given the young age of this patient and the way that they presented. So in terms of managing the patient, the most important thing initially is physio and airways clearance. So, all bronchiectasis multidisciplinary teams will have physiotherapists on board who are really vital to help patients with airways clearance, which can also help with day-to-day symptoms as well. Sputum sampling is important. We've already done that on our patient. As I mentioned, excluding any underlying immunodeficiency or treatable causes. Having a self-management plan for patients is really important if they develop infections, but also in terms of the regular daily physio routine. We might consider long-term therapies in patients. For example, long-term prophylactic antibiotics may be appropriate. And clearly things like flu vaccine are useful and important every winter. Pulmonary rehabilitation is also indicated for people with bronchiectasis if they are breathless to a considerable degree. In other words, they have an MRC dismiss score of 3 or worse. And clearly, a sort of an experienced multidisciplinary team is helpful to try and optimize care in these kind of patients. So if you want more information, the British Thoracic Society guidelines of bronchiectasis are a good read available via the BTS website. So this patient does have some investigations for cystic fibrosis, which includes a sweat chloride test, which comes back as being positive. And they also have cystic fibrosis genotyping, which shows that they've got 2 gene mutations for the delta F508 mutation, which is the commonest type of mutation in cystic fibrosis. So really, given the story, the age, the fact they've got bronchiectasis, and now the fact that they've got tests confirming cystic fibrosis, the diagnosis is cystic fibrosis, which has caused this patient's bronchiectasis. So we'll just briefly talk about CF. So firstly, can you describe the pathophysiology of CF? And then we might contemplate also the prognosis and management. So just thinking about the pathophysiology of CF first. Well, it's an autosomal recessive condition, and in the UK, generally affecting about 1 in 2,500 live births. And in a very basic nutshell, we have a sort of long arm chromosome 7 defect in cystic fibrosis, which leads to the cystic fibrosis transmembrane conductance regulator, CFTR mutation. And that leads to ineffective cell surface chloride transport, and that's in a variety of organs throughout the body. And that leads to thick dehydrated body fluids in organs which have CFTR. So a lot of organs throughout the body have CFTR. Just thinking about the current UK CF median predicted survival. So as you can see on the graph here, since CF was sort of detected really as a clinical entity in the sort of late 1930s by Dorothy Anderson, pictured here, clearly the survival has improved considerably over the last, whatever it is, almost 80 years. So there's multiple reasons for those improvements in survival, including an acceptance of improvement in nutritional replacement, the fact that patients need pancreatic enzyme replacement therapy, recognizing that different microbiological organisms can impact patients. Long-term prophylactic therapy is important. The newborn screening program, which was developed some 10 years ago or more actually in England and Wales, essentially is important because it picks up kids are essentially in infancy. So early diagnosis is important in helping. We've also now got considerable new treatments on the market. So cystic fibrosis transmembrane conductance regulator, modulator therapy, and potentiator therapies. And these are sort of really impressive treatments which can improve CFTR function in patients. So again, you don't need to know that in great detail. Clearly, if you're interested, then I can discuss that more, but that's just for your interest at the moment. So I guess the key message is that survival is improving, and it continues to improve for multiple reasons. CF is a multisystem disease, and it affects a lot of our main systems, not just the lungs. And again, this is because of the involvement of CFTR throughout the body. So we're not going to go through all of these in great detail. I'm just picking out a few. So thinking about the pancreas itself, now clearly the pancreas is a key organ which has both endocrine and exocrine functions. And the majority of people with cystic fibrosis will have what's called pancreatic insufficiency. In other words, the pancreas doesn't perform properly, and it eventually becomes very fibrosed, and you get a reduction in number of functioning cells within the pancreas. So the exocrine consequence of that is that they don't produce enough pancreatic enzymes. So things like amylases, lipases, proteases, which are very important when digesting food. So therefore, when patients who are pancreatic insufficient due to CF eat any considerable meal or snack, they need to also take supplemental pancreatic enzyme replacement therapy to prevent malabsorption. There are different sort of drugs available to help with that. One very common one we use in the market, the brand name is called Creon, which has a multitude of these enzymes in it. And again, patients will dose accordingly to what they're eating at the time. In addition, in terms of endocrine dysfunction, about 1/3 of adults with cystic fibrosis will develop cystic fibrosis-related diabetes, which is actually a different entity. It's not the same as diabetes mellitus. It's actually a unique condition, but it is also something which requires insulin treatment generally as a replacement, because in CF-related diabetes, the sort of pathophysiology results in an imbalance in insulin resistance in the body. So therefore, these patients generally require insulin to try and help treat that specific type of diabetes. Thinking about the gut, a very common complication of CF is called distal intestinal obstruction syndrome, or DIOS is something that we abbreviate that as. And essentially that is fecal impaction, usually in the junction of the large and small bowel, which essentially is the start of the ascending colon. And really that's because of the fact that there is CFTR in the gut, across the gut lumen. And as a result of that, within the gut lumen, patients can get thick dehydrated feces. And if that becomes the case, then it essentially, like plumbing, wedges in the area of the tightest angle, which is the junction between the large and small bowel, which typically sits around this area in the right iliac fossa. So patients often present with right iliac fossa pain, or they sometimes present with a fecal mass around that area, which can palpate clinically. So that's a really important common complication. The way that we diagnose DIOS essentially is an abdominal X-ray, which is just looking for fecal impaction in the ascending colon. Okay. So in terms of lifestyle advice for people with CF, clearly there's quite a few things that we need to sort of recommend, which are fairly common sense, which clearly is not smoking. You need to avoid other people with cystic fibrosis because there is a risk of cross-infecting each other. So if they have specific organisms in their lungs or bacteria, they can actually spread that from person to person by contact. Avoiding any friends or relatives who have cold infections at any point. And again, we're clearly more mindful of that recently with COVID. It's changed the way that we practice, but even prior to that, this was the advice that we were giving our patients. Avoiding scenarios like hot tubs and jacuzzis, because actually these can be harbors of pseudomonas, which can be quite risky for our patients. Sounds like a sort of common sense statement. Cleaning and drying your nebulizers thoroughly. With that essentially is because it's quite a laborious process. So if patients are on regular treatments, for example, antibiotics that they have to use through a nebulizer on a daily basis, cleaning the nebulizer sometimes can take up to 15-20 minutes per day. So you've got to sympathize that can be a process which some people might get fed up with. But helpfully, pharmacological companies are now starting to create a lot of treatments, for example, prophylactic inhaled antibiotics in inhalers. The benefit of that is, firstly, they're portable as opposed to the nebulizers. And secondly, the inhaled antibiotics, the devices are actually disposable. So they can use them, for example, after 1 or 2 weeks and then throw them away. So they don't need to worry about cleaning them. So there's some really good advancements from pharma which are helping our patients. People with CF need to avoid kind of farming type of environments, so avoiding stables, horse riding, kind of things like that, if they can. Having said that, I do have patients who enjoy that as a hobby, but again, all you can do is give them guidance, and the reason for that is they're at a higher risk of getting inhalation of things like aspergillus, which is a common fungus in the environment. Clearly, supportive measures like annual flu vaccine are very important, and also the use of sodium chloride tablets in hot weather, because CF patients will lose more sodium chloride than people without CF, and therefore things which would cause them to lose more moisture would be any hot environment, whether that's hot weather or work environments. For example, if you work in a hot kitchen, I've got patients who are chefs. They work in a hot environment all day. They would need to sort of take extra sodium chloride salt tablets. And clearly, if you're sweating during exercise as well, that's another indication to take more salt tablets. So in summary, the management of CF is actually fairly complex. It is led by specialist teams. There's only a sort of select number of commissioned services for CF nationally. So again, it's not available in every hospital. Essentially, CF teams generally try and provide fairly holistic care. In other words, they think about all problems that patients face. It's very multi-system disease, as we've mentioned. The key to long-term success in CF is maintaining really lung health in terms of chest physio, infection management, whether that's acute infections or prophylactic, long-term therapies. And also nutritional state is really important. So, body mass index is vital to sort of maintain that with, pancreatic, enzyme replacement therapies we've mentioned. Vitamins are important. So, fat-soluble vitamins, vitamin A, D, E, and K are more likely to be not absorbed in these patients. So, again, replacement with these is important. Generally, FEV1 and weight body mass index are seen as markers of long-term health. And really our goal as a CF MDT is to work with patients in partnership to try and maintain or try and slow the deterioration of their FEV1 and the body mass index down, and really try and minimize any deterioration if we can. As I've already alluded to, we've got some really exciting new targeted therapies aimed at improving CFTR function now being available. You may have seen about these in the news, and it really has transformed the way that we're going to look after our patients with cystic fibrosis. So, me as a CF consultant, I think this is great, and it's really fascinating that we've been able to develop some really novel treatments which do appear to have significant impact and benefit for our patients. Also, as a CF team, we're very mindful about managing all those other comorbidities. So not just lung problems, but we've got clearly, nutrition, diabetes, liver disease, and other things which affect people with CF. And I've mentioned at the bottom, concordance or drug adherence, essentially. So, and that's not just to drugs, that's also things like physiotherapy and exercise. And clearly, as humans, we are not always 100% concordant with any intervention. And therefore, it's up to us to work with patients in partnership to try and help them improve their concordance. There's various different ways that we can do that. As part of our CF MDT, we have a psychologist who has a huge input for this area. Also, our pharmacists can help with this area as well. But also, there are tools being developed, as you're aware of, various apps like fitness trackers, etc., which can be good motivational tools to help people with chronic disease, in some instances, help with their concordance. Okay, this is our fourth case, which is a 53-year-old man who has had a dry cough for 4 months. He's got a reduced exercise tolerance, which was previously unlimited, but now 500 yards. He's got hypertension on amlodipine. He works in a pub. He's an ex-smoker of 20 years, accumulated 50 and 1.5 pack years before, and drinks some alcohol each night, I guess partly because of where he works. So when we examine the patient, he's got some fine bilateral inspiratory crackles, described as being Velcro crackles. So that's kind of like when you have a Velcro strap, for example, on shoes, and you open that up. That's the kind of crackles that this patient's crackles sound like. And he's got normal saturations at the moment. So we can see the X-ray, clearly does not look normal. And the way that we describe that is clearly we've got diffuse changes. So if we look at all the zones, there seems to be some abnormality throughout all of the zones. We've got diffuse changes bilaterally. The X-ray just doesn't quite look right. And sometimes you look at it thinking, how do you describe that? Or what is it that's not right? But if you look closely at the cardiac borders, it's probably fair to say that they're not entirely crystal clear. You've seen other examples of normal X-rays where you've got a nice clear cardiac silhouette. Whereas on this X-ray, you can't really see the cardiac borders entirely clearly. You can kind of, roughly see where it is, but it's not very clear. So when you've got somebody who's got very diffuse changes on an X-ray and unclear cardiac borders, it's usually because of some sort of lung parenchymal condition. And when you think about X-rays, remember it's a 2D image. So therefore, when you look at this kind of slice, when you see some abnormalities in any zones of the lung fields, you don't actually know if on the 2D image, is that abnormality in the lung field, or is it, for example, at the front of the chest, on the skin? Is it something on the pleura, which is wrapping the lungs front and back, or is it within the lungs? But when you get this kind of hazy cardiac silhouette, if you think about how the heart sits, and our lungs wrap around the heart. So in other words, we've got lung. If you were going to take a slice, an X-ray through your chest, you're gonna essentially picture or take a picture with the X-ray of the front of your lung. Then you'll move the beam of X-ray, go through the heart, and then the beam will come out of the back of the lung, which is wrapped around the heart. So the reason we've got hazy shadowing of the cardiac silhouette is because of the fact that you've got lung parenchymal involvement all over, so front and behind the heart. This diffuse shadowing, it looks a bit sort of fluffy. That's kind of cotton wool-esque, maybe cantifloss. That sort of lay description, and that suggests that there's underlying alveolar shadowing. Reticular nodular shadowing is another medical description for this kind of picture. So we've got diffuse bilateral alveolar or reticular nodular shadowing with very unclear cardiac borders. And given the presentation of the patient and the examination findings of these fine bilateral inspiratory Velcro-like crackles, this suggests an underlying interstitial lung disease. Now, to confirm interstitial lung disease, or ILD for short, we need a high-resolution CT scan to look at the parenchyma in more detail. So this patient does have an HRCT, which does confirm ILD. Now, ILD is an umbrella term which is really used to describe a number of different conditions which affect the lung parenchyma. And there are loads of different subtypes of ILD, and you do not need to learn all of those. I've not listed all of those here. I've just mentioned a few common ones which are worth thinking about and things that we probably see more usually in our practice. So the sort of first one is something called usual interstitial pneumonia, or UIP. Now, this is based on a reclassification of ILD subtypes, which essentially was changed about, I don't know, 10, 15 years ago. And really this is something which we used to sort of call idiopathic pulmonary fibrosis or cryptogenic fibrosing alveolitis. And those names were a bit more explanatory in terms of what this condition actually is. I think UIP personally is slightly confusing terminology because essentially it just means ILD of unknown sort of cause with a specific pattern of distribution on the CT scan, and it's the commonest subtype of ILD that we see. There's certainly no infection or anything to do with pneumonia in UIP, so that's why I think that the terminology is slightly confusing. The reason that name has been used is because I think histologically, if you take a lung sample from somebody with UIP, the histology looks a bit similar to, for example, an infection like pneumonia. So anyway, just to sort of clarify that, UIP is the commonest subtype of ILD that we see. It used to essentially be called idiopathic pulmonary fibrosis. Another common type of ILD is something called non-specific interstitial pneumonia, NSIP, which differs to UIP mainly in the pattern of distribution on CT scanning, and you don't really need to know those at the moment. That's probably too specialist and postgraduate. And certainly if you're interested, by all means, you can learn about that, but I don't think at your level is required currently. The third thing on our list is extrinsic allergic alveolitis, which is also known as hypersensitivity pneumonitis, which essentially is ILD which results from some sort of environmental insult. So for example, this is why we ask patients, have they had contact with birds, or do they have pet birds? As example, patients inhale, things from bird feathers, which then cause some sort of reaction within the lungs, which leads to this hypersensitivity pneumonitis or extrinsic allergic alveolitis. Other conditions like farmer's lung, inhaling things in the environment can lead to this. Some drugs, medications can also lead to sort of a similar sort of pattern with extrinsic allergic alveolitis. The commonest drugs that we see which can affect or cause ILD would include things like nitrofurantoin, which is a very commonly used antibiotic for urinary tract infections, methotrexate, amiodarone. So those are the kind of drugs which can be causative of ILD. Sarcoid is something we mentioned here, as sarcoid essentially is a multisystem disease, which is idiopathic. We don't really fully understand what causes it at the moment. It's characterized by histologically non-caseating granulomas. So that, again, being a multisystem disease can affect a variety of organs, typically the lungs, but it can also affect skin with changes like erythema nodosum. It can affect your eyes with uveitis. So you can get renal involvement, neurological involvement, liver involvement, cardiac involvement. So, again, it can affect a whole host of different parts of the body, but lungs are usually the most commonly affected part. And that is, again, can lead to changes within the parenchyma, which look like fibrosis on a CT scan, in keeping with being a subtype of ILD. So again, just a very sort of basic outline. Most interstitial lung disease are typically restrictive lung diseases. So on spirometry lung function testing, if patients have significant involvement in their lung parenchyma, they're likely to demonstrate restrictive spirometry. For new diagnosis for ILD, we should think about those underlying causes, because that will help with our investigation process. And there is an association with connective tissue disease, rheumatoid disease, some sort of vasculitis as well. So therefore, these kind of blood tests, are very appropriate. And ACE level is something that we also do because people with sarcoid often have a raised ACE blood level. And we can also do something called serum precipitants, which is essentially specific things if we think are causing our patients underlying ILD. For example, if they had a PET budgie, then you can actually do an IgE, which is specific for Budgie-Gar. So again, you need to give those details to your immunology lab so they can do the appropriate test for you, depending on what the history of the presentation is. So ILD treatment principles, well, that will depend on the underlying pathology, but also the underlying subtype of ILD. The general principles for management, make sure we've taken a really detailed history. As we've said, is there something in the environment or even occupationally which is contributing? And therefore, if that's a trigger, then we can try and remove that trigger. Is there a drug causing it? Again, if so, then we stop that particular drug. As with all chronic respiratory disease, obviously stopping smoking is very important. And there's also quite a few novel therapies being used for ILD patients, depending on a variety of parameters, including subtype of ILD, but also lung function testing, etc. And again, you don't really need to know these at the moment. It's really more postgraduate. But again, if you're interested, you can look into this in more detail. There's good guidance on ILD approaches via the BTS and NICE websites. But again, I don't think you need to know that in great detail at the moment. Clearly, anyone with ILD who presents with an infection needs appropriate treatment for infective exacerbation. As we've talked about with our COPD patient before, for long-term oxygen therapy, if that's appropriate, same criteria, then we might use that. Clearly, there's an MDT approach for this chronic disease as well, and we might consider the likes of transplantation if very severe progression and the patient's a candidate with no contraindications for lung transplantation. And like many other chronic lung conditions, ILD is generally progressive and not curable, and therefore we're likely to require involvement of palliative care teams as it becomes more progressive and more debilitating for a patient. So in summary, we've explored 4 sort of typical referrals from primary care into the respiratory clinic. I guess the idea of this presentation was to try and highlight the differences in acute versus chronic disease care. We've talked about acute care in other presentations. For example, when we talk about people presenting to admissions units or as inpatients. As before, I'd recommend that you use this presentation in conjunction with completing your workbook respiratory cases, and don't forget you've got your respiratory booklet, which can also be helpful with supplemental information in that. And interestingly, all 4 cases that we've talked about today actually all presented with a cough. Clearly, they've all had very different diagnosis in the end. So that really just leaves us on this final slide, which just reminds us really of a general approach to chronic cough referrals, because just remembering cough is really one of the common symptoms that is seen in primary and secondary care. So just as a general overview, bit of a useful way of thinking about different causes of cough. And again, really reminding ourselves that we need to encourage patients not to ignore symptoms, to be seen promptly, and to think about getting prompt X-ray, particularly if they've had a cough which lasts 3 weeks or longer. Thanks for watching.